So you can start now.
Okay. Good afternoon, everyone. I'm Dr. Kavin from the Department of Respiratory Medicine. In today's webinar, I'll be discussing about a case of hemoptysis. This is a patient who have been admitted in our department recently. So first we will see about the case history of the student. We may call him Mr. S. So Mr. S, about 21 years of age, who's a college student from Majida Rangpo. He was referred from Sikkim Hospital, where he was admitted for 3 days. And the reason for referral to CRH is he is having now an increased amount of hemoptysis. He was received in our ER and call was given to a duty doctor. The patient was initially treated symptomatically in the ER and stabilized, and history was collected from the parent. His mother was accompanying him when he got admitted. So the history as given by the parent was he suffered from chest pain, which was sharp and central, and there was no radiation. The chest pain was for about 7 days. He also had hemoptysis. Initially, it was around 100 to 200 ml for about 2 to 3 episodes per day. But recently, from today, it has increased in amount. And also fever after he got admitted in Sikkim Hospital, but there's no any evening rise of temperature or any chills or rigors. So when we clinically examined him after he got shifted to the department, his vitals, his blood pressure was normal, about 120/70. His heart rate was slightly increased, around 112 per minute. His saturation was low, and at 86% at room air, but it improved after we kept him on oxygen at 3 liters per minute. His cardiovascular examination was normal. There were no murmur present, and his respiratory system examination, we had normal vesicular bed sound. There were no any adventitious sound. So with the history of fever, chest pain and hemoptysis, and with fairly normal clinical examination, we admitted him under a working diagnosis of an community acquired pneumonia, most probably, and also to rule out tuberculosis because the patient had hemoptysis, keeping in mind the age of the patient and also his symptoms. So we were most probable, we were thinking about a most probable diagnosis of TB. So further, he was several investigations were done on him. He did had some investigations done from Sikkim Hospital, but they were not complete. So we did some test again. So his blood counts were normal. His liver function test and kidney function test were also normal. And his PT-INR, because he was having hemoptysis and he's an young patient, so we also did a clotting profile of PT-INR, which was fairly normal. And the sputum investigations, we were not able to do because the patient was still having an active hemoptysis. So we thought that we will do in sputum investigations after the hemoptysis have resolved. We did an ECG from the ER, which showed only sinus tachycardia. And we did also an HRCT thorax from the ER. So the HRCT showed some homogeneous opacity, which is pleural based. And the report we got was it was a consolidation and a bronchogram in the left posterior basal segment. So we were fairly convinced because we also thought that it could be a pneumonia, and the CT report also gave us that it was a consolidation with air bronchogram. So we thought we would proceed in favor of community acquired pneumonia and treat him with antibiotics. So he was started on IV antibiotics, and also he was given IV tranexamic acid 3 times per day. 3 times per day to control his hemoptysis, and also as he was having active bleeding, we also put him on some anxiolytics so that he can have good rest. Course in the hospital in day 1 and day 2, he was fairly showing improvement, but suddenly on day 3 he complained of a chest pain, the same chest pain what we had when he got admitted, but this time it was still more than the previous time, and his hemoptysis has not settled even after 3 days of admission in CRH. On examination, again he had still persisting sinus tachycardia, but he was afebrile. So we thought that this may be probably because of his chest pain. He is having this and this sinus tachycardia. So we stabilized him with some painkillers. Again, he showed good improvement with the painkillers. So on the day 5, we again arrived at the further ward round. So he said that his there was no clinical improvement. Even his parents, his mom was so worried that because his hemoptysis is still persisting, and also his chest pain is okay when he takes painkillers, but it again recurs when he is off painkillers, and still he had a sinus tachycardia of around 102 or 22 per minute, and also saturation is not improved for it is still being 86% in room air. So even after giving him good antibiotic coverage and also tranexamic acid for hemoptysis, there was no good improvement for almost after 5 days of admission in CRH. And also but the most worrying point here about the patient was his saturation, which is not improved. Well, it was same 86 when he got admitted 5 days back, and also now the same 86. So we were a little worried why the patient is not improving. We thought maybe the patient could have ended up in some complication of pneumonia. But to our surprise, we found two important findings on that day on examination. We heard a pansystolic murmur in the left sternal border, which was not present when the patient got admitted 5 days back. But this was a new murmur that we got on the day 5th day. And we also saw JVP, which was increased, which was also not present when he got admitted. So now we are left with no answer because we thought that it could be a pneumonia, but now we have a new sign of a pansystolic murmur and increased JVP. So we thought we are not dealing anymore with pneumonia, so something to do with heart or a cardiac problem. And with pansystolic murmur and also JVP, so we thought that his right heart is under some problem. So we thought we would move ahead with doing an echocardiograph. So in echocardiogram, the ejection fraction and all other parameters were fairly normal, but the most striking feature we found on echocardiogram was his peak TR gradient. We showed a very severe tricuspid regurgitation. The pressure was around 71 millimeter mercury, and also its RVSP, the right ventricular systolic pressure, it also showed a very severe increase in pressure of around 81 millimeter mercury. So with all these findings of severe tricuspid regurgitation and also severe pulmonary arterial hypertension with RVSP value, so we thought that his heart is maybe under problem. So we also saw the 2G echogram picture. It can clearly show that both his right atrium and right ventricle are distended enormously, and this distension has caused the left side of the heart to compressed. You can see that left atrium and left ventricle are almost compressed because of the distended right chambers. Apart from it, we also got a very minute pericardial effusion in the anterior aspect, and we saw the valvular functions were normal. There were no any valvular pathology, nor there was no any intracardiac abnormality. So even though the patient had some right heart abnormality, so the problem is not actually in the heart, so it is somewhere else. So the most probable thing we thought maybe from the lungs, because of the back pressure, his heart is also compromised, which has led to all signs and symptoms. So to rule out any other pathology, we have already had an CT, HRCT done when, during the admission, but that didn't reveal anything much except for the consolidation. So we thought we will move on with an CT angio to look out for any abnormality in the angiography. So on the axial cut, we could see the common trunk, the pulmonary trunk is enormously distended here, and also his right and his left pulmonary artery also showed distension. And further in the CT angio picture, we can see on the right upper lobe segmental arteries, we can see there was a filling defect, and also on the left side interlobar artery, there is a lobar lobe artery. Again, we saw a filling defect in the left interlobar artery. So we saw a prominent pulmonary trunk, prominent both right and left pulmonary artery, along with some filling defects. So we arrived at an diagnosis of an acute pulmonary embolism in this patient. This was not in the differential of this patient when the patient got admitted, because we were thinking, keeping in mind the age of the patient and also the symptoms of fever and hemoptysis and chest pain, we thought that this could be mostly in community acquired pneumonia or in tuberculosis. We never thought that it could be acute pulmonary embolism, because the history also didn't suggest anything towards the acute pulmonary embolism. So we now have to we do have a diagnosis at hand now of acute pulmonary embolism, but we have to assess him further to know what was the cause of his pulmonary embolism. So the first thing, we went retrospectively and did in Doppler. We did see thrombus in the deep venous system, both in the popliteal veins, both on right and left, but more on the right side. And we also did in D-dimer, and the D-dimer was also increased in them. It was around 1,353. So we were pretty sure these may be the that it is a pulmonary embolism, and it is from the deep vein thrombosis. But still we were not arrived at a cause for why the patient had an DVT in the first time. So though keeping in mind the young age of the patient, we thought maybe the patient is having some congenital or an inherited coagulative abnormality, because there was no any other history which put him in a high risk for pulmonary embolism. So we run also a protein S, protein C, and an antithrombin 3, but all reports turned to be normal. So this was also not the case with this patient. So this made us to bombard ourselves with all other causes of pulmonary embolism. So the patient now has been diagnosed with venous thromboembolism. That means he is having both a deep vein thrombosis of leg along with an pulmonary embolism, which also complicated with an pulmonary infarct. The first CT what we saw when he got admitted, that must be most probably an pulmonary infarction, not an pneumonic consolidation. So after we came to know about the symptoms, but we still were thinking about what could be the cause of a venous thromboembolism. So we again went back to the patient and took history from the patient, because when the patient got admitted, we got the history only from the parent, because the patient was not in the condition to reveal any history. So what we have missed, and also patient missed in this diagnosis, is about the history, because the patient stays alone in a hostel, and he said that he was dehydrated after a binge alcohol drink, and he was bedridden for around 4 days before he reached Sikkim with the symptoms of chest pain and hemoptysis. And he also said that he had a history of substance abuse, both alcohol and also IV drug abuse. So what we have missed in this patient, or what misled us to not think about pulmonary embolism was HRCT thorax, the first report, because the first report confirmed a probable diagnosis of an community-acquired pneumonia by giving a consolidation and air bronchogram. And we didn't do a sputum in this patient because the patient was still bleeding at that moment, and we didn't look out for any signs of DVT in him, like calf tenderness, or also didn't elicit any history of DVT, because that was not in our mind that this patient may be a patient of a thromboembolism. So after we diagnosed him as in pulmonary thromboembolism, we started him on novel oral anticoagulants, dabigatran 100 mg twice daily, and patient has been discharged after a brief 10 days of admission, and he was sent home now. He is under a regular follow-up now. So this was an interesting case that I wanted to say you, that we never thought that this patient could be a case of an acute thromboembolism, because the patient didn't reveal any history, and we were thinking about a case of an tuberculosis, but at last it turned out to be an embolism. So I like to highlight some points regarding the pulmonary thromboembolism, as we should also keep in mind if we are dealing with patients with hemoptysis. So I'll be briefly saying you about the risk factors, the updated diagnostic algorithm, and also an updated treatment for pulmonary thromboembolism. All these updated treatment and algorithm are taken from 2019 European Society of Cardiology guidelines. So the risk factors, the strongest risk factors with an odds ratio of more than 10, the most common was fracture of any limb, or hospitalization for heart failure or any other cardiac problems, any recent hip or knee replacement, any major trauma, recent myocardial infarction, or a previous history of an thromboembolism or a spinal cord injury. Our patient didn't have any of these strong risk factors. Other moderate risk factors with an odd ratios of 2 to 9, where any recent knee surgery and other autoimmune diseases, sometimes even after blood transfusions, or the patient under chemotherapy, patients who are pregnant, patients who are postpartum, or patients who are on oral contraceptive therapy. Yes. Then some weak risk factors with odd ratios of only 2, bed rest for more than 3 days, diabetes, arterial hypertension, immobility, increasing in age, or obesity. So of all the risk factors from the history, we got only in our patient, we had the bed rest as the only risk factor what we can see. And after you suspect the patient may have an pulmonary embolism, it is important that you have to clinically predict what are the chances that the patient may have an embolism. There are various methods to predict it. One is clinically you can predict by seeing the signs of DVT. There are some scoring systems available. The most used scoring system was Geneva revised system. Another one is in Wheel score. So here we will see about the Geneva prediction, which is practiced widely. So there are both original versions and simplified versions to be used by the physicians for easy calculation of the risk score for probability of an DVT. So there are various parameters. The first one is a history of a DVT, the heart rate, any fracture, hemoptysis, an active cancer, unilateral limb pain, or deep venous palpation or edema, or if the age is more than 65 years. If all these criteria, our patient had on admission, his heart rate was more than 100, so he gets in 0.5 in the original version and a 2 in the simplified version. And also on admission he had a massive hemoptysis, so on original version he gets score of 2, and in simplified version he gets score of 1. So on totally, his original version score is 7 and the simplified version score is 3. So with this score, we can now predict based upon the probability criteria. Either we can put in the 3-level score on the 2-level score. According to the 3-level score, he fits into the intermediate risk for a pulmonary embolism, and in 2-level score, he fits into the pulmonary embolism likely because his score was more than 7. So with this, the next thing after we have clinically predicted that the patient might have a probability of a pulmonary embolism, the next course of action deciding based upon the probability. So the first thing that we see as our patient is under intermediate category, the next thing that we should have done is an D-dimer assay. So if the D-dimer assay turned to be positive, then we move on to the next course of action, that is in CT angiography. Either if the CT angiography is confirmed, then you have to treat the patient for an pulmonary embolism. So D-dimer plays a role here to exclude the diagnosis of pulmonary embolism. So now, according to the newer guideline, the recommendation for diagnosis if the patient is without shock or hypotension, the first important is then clinical evaluation from history, and also clinical judgment is the most important thing. And apart from it, D-dimer plays an important role. The plasma D-dimer measurement is recommended in outpatients and also in emergency department, and this is important to reduce the unnecessary imaging for patients as this have a high sensitivity assay. Other recommended modalities that we can use if we think of a higher probabilities in lower limb compression ultrasonography, which will give us if the patient is having a deep vein thrombosis, and also a pulmonary angiography, what we did in this case. Sometimes even magnetic resonance angiography can be done, but that is not recommended in the newer guideline. Recommendation for diagnosis: the patient who presents to the emergency with shock or the patient is in hypotension. So you cannot, you don't have much time in hand to go about the stages of doing a D-dimer, doing a compression ultrasonography of both limbs, or doing a CT angiography. So you can directly go for an CT angiography in these patients, and you can also start the treatment then and there. It is also important that you have to look, you have to do a 2D echocardiography to see for any RV dysfunction, because this may affect the further prognosis of the patient and also management of the patient. So after we have diagnosed the patient of pulmonary embolism, the next important thing is in post-test probability of the risk or the severity of an pulmonary embolism. This is given by the score PESI, that is a pulmonary embolism severity index. It contains various points. So it also have two versions, the original version and the simplified version. If we see in our patient gets 10 points for sex, and also he gets 20 points for his pulse rate because it was more than 110 when he got admitted. So and also his saturation was low when he got admitted, which was less than 90. So he gets an additional 20 points. So according to the original version, our patient, Mr. S, gets a point of 20 plus 20 plus 10, that is around 15 original version and 2 in the simplified version. So this severity index helps us in the further management of the patient and also treatment, and also it also predicts the recurrent risk of an pulmonary embolism in the patient. It is also important that this index is done for every patient so that we can formulate the treatment for this patient and also the duration of treatment for these patients. So according to the patient had almost more than 50. So the patient comes under low mortality risk. So this patient can be managed at home with oral anticoagulants. If the patient's class was more, then the patient may be in higher mortality risk. So these patients should be admitted in hospital and should be treated in the hospital. But our patient, as he falls under the low mortality risk, it is okay that we start him on an oral anticoagulant, and we can discharge also back home, and we can ask him for a regular follow-up in the clinic. Because in our patient, an echocardiography, the patient did show some features of an right ventricular afterload, like there was an right ventricular dilatation, there was an tricuspid insufficiency, there was also some wall tension, but the patient was stable. So we have fairly diagnosed the patient of pulmonary embolism in an earlier stage, or the embolism was not that big enough to cause an severe RV afterload, severe RV dysfunction leading on to shock or an hypotension. So now we have diagnosed a patient with diagnostic modalities. We have also categorized the patient according to the risk of the patient. Now we will see how we can treat a patient of an pulmonary embolism by the new algorithm. So in our patient, the first you have clinically suspected case of a pulmonary embolism. The first thing that you have to see is whether the patient is in shock and hypotension. This shock or hypotension may suggest that the patient may be in an RV dysfunction. So the diagnosis and treatment should be prompt and should be earlier. But our patient didn't have any shock or hypotension. So if the patient had any of the shock or hypotension, then we have to do as I said earlier, a 2D echogram. The patient falls under a high risk category, and immediately you have to start the patient on a fibrinolytic for a primary reperfusion. Like we can start him on a streptokinase or an alteplase, and this is necessary. But our patient was not in shock or hypertension, so he falls into the second category. So we have assessed also his severity index. So he actually falls under the low risk. So we started him directly on an oral anticoagulant, and we also discharged home because as per the guidelines, and home treatment is advisable. But some patients, if the patients falls under the intermediate risk, then it depends upon frequent echo monitoring to see for any RV dysfunction, and it also depends upon clinically how the patient is. So if the patient has an intermediate high risk, again we have to consider him or her for a reperfusion, or if the patient is low risk, we can start him or an anticoagulant, but hospitalization may be necessary. So what is the change when compared to the previous algorithm for treatment? Previously, for treatment of pulmonary embolism, the recommended was to start the patient on a low molecular weight heparin or fandaparinus or enoxaparin, an injectable. But now the guideline says that you can directly start the patient, if the patient is in low risk, you can directly start the patient on an novel oral anticoagulants like dabigatran. That's what we also did. We started our patient on dabigatran, and we also discharged the patient for home treatment and follow-up. So what are the main goals of embolism treatment? The initial treatment, we start the treatment initially to stop the propagation of the clot, to prevent any further embolism, and to protect the pulmonary circulation from the deleterious pressure, and also to restore the venous return to the body. And the long-term prevention, we prevent any recurrence of VTE, and also we also take care of any post-thrombotic symptom the patient may have, like in pulmonary infarction. And also we have to also take steps to prevent a chronic thromboembolism, the CTE PH. And keeping all this in mind, as we are giving the patient an anticoagulant, we also minimize the bleeding risk for the patient by frequent monitoring if we start the patient on heparin or fandaparinux. So treatment in acute phase, according to the newer guidelines, so we have to first start the patient. If the patient is in low risk, to a novel oral anticoagulants. This is a new recommendation from the 2019 guidelines from the European Academy of Cardiology. But previously, as I said earlier, this was with injection low molecular weight heparin. This is a newer recommendation, and by this recommendation, we started our patient on an oral anticoagulant. For chronic treatment for 3 months, the recommendation says that previously we classified the pulmonary embolism patients into a provoked and an unprovoked pulmonary embolism based upon the risk factor what the patient has. But now all these terminologies have been washed away, so we don't there's no need of using words like provoked or unprovoked, because we now have a scoring system, the PESI system, that is a pulmonary embolism severity index system, where we score the patient, and based upon the score we manage the patient. So this patient, as the patient had an risk factor like in prolonged bed rest and also dehydration, so we are planning to in the initial stage to treat the patient for 3 months with oral anticoagulants. So the some words, few words on the oral anticoagulants. So we all know about the warfarin and other vitamin K antagonists. The newer ones are the direct thrombin inhibitors and the activator factor 10 inhibitors. In direct thrombin inhibitors, we have the dapigatran, the drug which we started in our patient also, and other activated factor 10 inhibitors like rivaroxaban, abixaban, and endoxaban and betrixaban. FDA has approved all these drugs for pulmonary embolism treatment. The most commonly used are dabigatran, rivaroxaban, and apixaban. So to know about the mechanism of action of these oral anticoagulants is necessary, because this is completely different from both heparin and also vitamin K antagonist. The direct factor 10 inhibitors like rivaroxaban, abixaban directly affect the factor 10A. The dapigatran affects the factor 2A. Factor 2A. So if we see the various properties of all these novel anticoagulants, dabigatran is a prodrug, all others are not the prodrug, and half-life elimination is in about 14 to 17 for dabigatran, for others are all 7 to 11. And elimination also, dabigatran is mostly by renal route, rivaroxaban, abixaban, all those mostly by hepatic and stool route. Drug interactions are more common in dabigatran when compared with other oral anticoagulants. So what is the difference between dabigatran, the direct inhibitor, and also the factor 10 inhibitor? The monitoring is necessary for dabigatran still, because it's a direct inhibitor, but the activated there is no need of monitoring for other class of drugs. As I said earlier, in acute phase, if the patient is in shock or hypotension, we may consider a reperfusion therapy like an RTPA, a streptokinase, or an urokinase. But these do have some absolute and relative contraindications. Other treatments which were there for a very long time was surgical embolectomy, which is a very invasive procedure. And the newer method is in catheter-directed treatment, where by a catheter we can deliver a thrombolytic or a fibrinolytic directly into the clot so that it can dissolve the clot. It does also carry any risk of further microthrombi, but still this has proven results now. So now coming to the end of my presentation summary, the first and foremost thing is you have to keep in mind that for hemoptysis, pulmonary thromboembolism is always a cause, irrespective of the age of the patient or even if the patient is not giving any symptoms. So please screen for all patients with hemoptysis for pulmonary embolism. Other summary from the guidelines, the newer guidelines, is the D-dimer. D-dimer is an important test it should be considered, because if you think the clinical probability and high, and also on compression ultrasonography also can be considered if there are high risk, or if you think there is a high risk of an pulmonary embolism. Another newer inclusion in the guidelines is assessment of the RV dysfunction, which was not included in the guidelines in the previous 2014 report, but in newer guidelines, RV dysfunction should be imaged. It can be done both by 2D echocardiography regularly and also by some biomarkers like BroPNP, etc. And the next important thing is in severity scoring, that is the PESI scoring. They stress upon that every patient should be assigned in PESI score and management should be based upon this PESI score. And the next important change in the guidelines is we can start if the patient is in low risk. According to PESI, we can start the patient directly on an oral anticoagulant like a dabigatran or apixaban. There's no need of starting the patient on heparin or low molecular heparin or a fondaparin, etc. And the extension of anticoagulation is also a newer thing in this guideline. So the extension should be considered for patients with no identifiable risk factors. For the index P event, like for more than 6 months, like for more than 3 months up to 6 months, we can consider giving patients an oral anticoagulant. And also if the patient have some risk factor or have an inherited disorder like an antiphospholipid syndrome or a thrombo, we should also give we may also give extend the patient lifelong an oral anticoagulant. Thank you. That's the end of the presentation.